here and joining. So welcome to our Introduction to STARS and first episode program, Lunch and Learn. Hopefully we're not giving you lunch, so hopefully you have your own lunch and you can just sit and enjoy and learn. So we are going to talk about this program that we're developing and that has actually started. So back in 2021, the centers got a wonderful grant from SAMHSA to start our behavioral health urgent cares, as well as to open a center for schizophrenia. So we know our urgent cares are humming and doing wonderful, and our STARS program is now humming along too. And we want to tell you about it from like a big overview and tell you how to get patients involved. Nate, would you go back one slide real fast? So I just want to introduce our overall team that's going to be presenting to you today. So myself, I'm Dr. Yancher, I'm the medical director of the STARS program. Nathan Rea, who's the director of specialized behavioral health services. Steve Raffiti, who's the program manager of the STARS and the first program, and Micah Stoudemire, who's the program manager for supported employment. So you'll be hearing from each of us today. Thanks, Nate. So the STARS program is the Specialized Treatment, Advocacy, and Recovery Services for people with schizophrenia. That's our big overarching program. So we have a few tenets that we believe kind of as an organization and as a team that people with schizophrenia can and do live healthy, meaningful, and rewarding lives. We support this by having developed a program that provides treatment and resources needed for those affected with schizophrenia. And our focus is really on early intervention and integrated and comprehensive services, not only from a first episode of psychosis, but across a person's lifetime. And also one of our big tenets is we want to provide training and educational experiences also for those that want to learn about working with this population, because that's how you get more folks dedicated and passionate about working with this patient population. Next slide. Oh, you did it. Okay. So we are essentially planning to offer comprehensive treatment for patients. This is a little bit redundant, but to both patients and their families and their communities to support them from their first episode of psychosis throughout one's life. What we include is a first program, which I think we'll talk about in more detail. This is evidence-based coordinated specialty care for individuals who are experiencing their first episode of psychosis, and we'll go over what that means, I think, in another slide. You're going to hear a lot about coordinated specialty services. Those services that are provided in our program include psychiatry, counseling, case management, supported employment and education, family psychoeducation, individual resiliency training, and medical care. So we aim to be able to wrap around these patients and give them everything they could possibly need to succeed.
It's so good. Yeah.
And this kind of just shows you the 5 main areas of care and support in our integrated care and support. So family and peer support, psych care, primary care, community advocacy and stigma busting, which we'll talk about a little bit later, and then behavioral health and substance use services. I think just a note overall, so we're all on the same page about schizophrenia, and when we're talking about schizophrenia, what we're really talking about. So it's a chronic and disabling illness. It affects a large amount of people in the world, about 20 million people worldwide. It's characterized by these periods of sustained psychosis, which is, of course, what we all are familiar with, right? What we see most often, and then a more longer-term functional deterioration in many different aspects of a person's life. It affects about 1% of our overall population, and it's equally distributed among men and women, among sexes. It is one of the top 10 leading causes of disability in the world. And while it affects men and women equally, the onset for the average onset for men and women is a little differently, with men having it the onset a little bit earlier than women. But again, this is averages and things fall within and outside of those ranges. The onset of actual schizophrenia is typically defined by the emergence of psychosis. And then the most common symptoms of psychosis when you're hearing about that are delusions. So, beliefs in things that are, these are fixed beliefs in things that are not real, hallucinations, so most commonly auditory hallucinations, but can also be visual hallucinations or even tactile hallucinations. Disorganized speech, disorganized behaviors, and paranoia. And then a little bit about first episode psychosis. So this really refers to the first time an individual experiences those psychotic symptoms or their first psychotic episode. And this is important for a lot of reasons. I know Dr. McNamara is on here, and I heard her explain it so well yesterday. But the earlier you catch someone in their first episode, with their first episode, the better their outcomes. So the more psychotic episodes a person has over a lifetime, the more functional deterioration they have in their overall cognitive functioning. So that's why it's so important to try and catch and treat and help support people in their first episode. And this first episode, as I said, frequently presents in late teens to early 20s. About 3% of people experience some psychosis at some point in their lifetime. That's not all due to schizophrenia, but it is a fairly common experience. And in the United States, about 100,000 adolescents and young adults experience a first episode of psychosis every year. All right, I think I'm going to pass it over to my colleague. I don't know who's coming next.
I will be coming next here.
All right, Nate. There you go.
All right. Well, thank you, Ellie. It was a great overview of schizophrenia and first episode stuff. So for the group here today, I want to start off my slides here with a little bit of an exercise, if you would. So for a moment, imagine that you're 17 years old again. Think about what you were going through then. What was important to you? What were you planning? What was your life like at that point? Now for a moment, think about all that you were learning and developing and dreaming at the time, and what it had meant to you if you were hospitalized and that others were saying that how you saw the world was not right. Imagine that you heard the words psychosis or schizophrenia associated with you and how you would react to that. So just take a moment with that for a second. Excuse me. So, I think or actually Dr. Yanchart did allude to something that I wanted to make sure that we talked about a little bit before I go further into stigma and discrimination, and that's that duration of untreated psychosis. Early treatment of psychosis is definitely shows to improve better outcomes for clients in regards to symptom management, relationship management, and hospitalization over that person's lifetime. And so, as mentioned, Steve will talk about our first services here later on, but really our goal is to reduce our goal is to intervene and to reduce that duration of untreated psychosis so that we can have better outcomes over a lifetime. So let's talk a little bit about how stigma, discrimination, and racism affects treatment and what we can do about that. So as mentioned, psychosis is a highly stigmatized symptom of and one that's not a one-dimensional problem. Society perpetuates the myth that a person with schizophrenia can be scary, violent individuals, even though it's been shown that people with schizophrenia are more likely to become victims of violence rather than the perpetrators of violence. Still, this mindset keeps individuals and families from seeking the support that they need. And so that intersection of stigma, racism, and discrimination really compounds the effect. And it's really important for us in our services that we're trying to mitigate the stigma so that we can, through our empathetic, respectful, and affirming treatment. All right, so to start, we have to be mindful of how we as mental health providers may have contributed to this problem. In 2021, the APA released a statement on this topic, and I quote from this: "Early psychiatric practices laid the groundwork for inequities in clinical treatment that have historically limited the quality access to psychiatric care for Black, Indigenous, and people of color. These actions sadly connect with larger social issues such as race-based discrimination and racial injustice that have furthered poverty along with other adverse outcomes." So what do we do? What do we see today as a result of some of these groundworks of inequities? So as you can see, in recent studies, they found that Black individuals are 2.4 times more likely to have been diagnosed with schizophrenia versus white individuals, oftentimes through misdiagnosis. If you've sat in on the presentation that Julia Bryant Bay and myself do when we talk about systemic racism in healthcare, we talk a great deal about schizophrenia in particular and the history of schizophrenia and its association with the civil rights movement. So if you have not been in that training and you would like to attend, please send me a message so we could talk about that a little further. So another thing that has an effect on that now is that presently the specialized treatment for early psychosis services really hasn't been targeted much into populations that are racial or ethnically different from European culture, right? So that is definitely something that you can see in the treatment modalities as it stands now. And then finally, young people from racial and ethnic minority groups experience psychosis often, or who are experiencing psychosis often enter in through into mental health treatment through what we would consider toxic treatment pathways, including interactions with the police and disempowering emergency hospitalizations. Now, just to note real quick that the pathways to care here is very important. That toxic treatment pathway reinforces stigma associated with psychosis and schizophrenia spectrum disorders. So if you think about it, if someone's experiencing psychosis and they're picked up by the police and they're handcuffed and they're put into the back of a police car and whisked away to the hospital, and all of that kind of reinforces this idea that they're dangerous or that they're not going to be accepted. And persons who are from racial and ethnic minority groups are more likely to experience these toxic pathways to treatment. Because of that stigma that's reinforced, we see longer durations of untreated psychosis and the greater chances of poor future outcomes. So what can we do about that? How can we make a difference with the clients that we're serving in our program? So in 2019, they asked, they did some research around what is important to those from racial and ethnic minority groups. And the top 3 concerns for these folks were as follows. 1, they want to get back to normal. They want to go to school. They want to go to work. That's really important. When I was 17, it was really important for me that I continue on with my education and go to college. That was extremely important to me, and it would be no different for anyone who's coming into our first program. Making mental health care available in their own communities. Huge, big piece of this as well. And then finally is that reducing that police involvement with their pathway to care. This is traumatizing, it's stigmatizing, and it definitely has that effect on their future treatment. So as the STARS program, we're really going to be dedicated to trying to make sure that our services provide a pathway that allows individuals to come into our care without having the trauma related to some of these other kind of toxic treatment pathways. And that once they're here, that we understand, or we inform our practice with we inform our practice with trauma-informed approaches and understanding of racial or ethnic differences. And so the first step in this within the STARS program is to is the first program that we've been talking about, and I believe that Steve is going to pick up and talk to you all about the first program today.
Hi, everyone. All right, let's dive into the first program and see what it's all about. So first is a program that has been developed for the early identification and treatment of first episode psychosis. It is a community-based comprehensive treatment approach provided by an integrated team of specialists with the goal of improving the mental health and quality of life for individuals who have experienced the first episode of psychosis. We are a multidisciplinary team, with each of us collaborating with one another to help the individual create a personalized treatment plan based on their goals, needs, and preferences. We are privileged to have the support and expertise of the following organizations to help us with funding, ensuring the program adheres to fidelity, and having access to a team of consultants to guide us as we develop this program. The new first episode team at the centers is supported by the Best Practices in Schizophrenia Treatment Center at NeoMed, the Ohio Mental Health and Addiction Services, and SAMHSA's CMHC grant program. All right, let's talk about the benefits of participating in a FIRST program. The program emphasizes shared decision-making and encourages the involvement of family or other supports in the individual's treatment. Because of this, clients have shown to develop more rewarding and supportive relationships with their friends and family. This program also emphasizes recovery through work, which means that employment, education, or other goals are important factors that help individuals find purpose and improve functioning. Clients in the FIRST program have been seen to display an increased ability to make progress towards working or volunteering in the community, academic advancement, and other important life goals. Additionally, early identification and treatment of first episode psychosis is found to improve the long-term course of the illness and reduce the likelihood of relapse or rehospitalization, and overall a decrease in symptoms of psychosis. So altogether, the benefits of this program can lead to a decrease in the overall cost of treatment on the mental health system. FIRST offers 5 treatment modalities within the program, and when we discuss the criteria on the next slide, you will note that clients must select a minimum of 2 services of their choosing to be a part of the program. We offer psychiatric care, individual resiliency training alongside individual counseling, supported employment and education, family psychoeducation for the support system, and case management services. And as you can probably imagine, experiencing psychosis for the first time can significantly derail a person's life and can impose many challenges that one may not know how to navigate on their own. So we're working to fill the role of peer support specialist as an additional component of treatment. However, it's important to note that peer recovery support will not be considered one of the 5 treatment modalities. Think of it more of as an extra layer of support for the individual and support system as they navigate the challenges of treatment and life after the onset of psychosis. All right, on to criteria. They're between the ages of 15 and 30. They're diagnosed with a schizophrenia spectrum disorder. They have experienced no more than 24 months of psychotic symptoms, whether treated or untreated, and they consent to participate in at least 2 of the 5 treatment modalities we discussed on the previous slide. It's important to note, though, that our clients are considered on a case-by-case basis. So if the individual does not entirely meet everything listed here, for example, let's say they're 34 years old or they've had 30 months of psychotic symptoms, it does not necessarily disqualify them from the program. As Nathan was saying earlier, we have to acknowledge that an individual's pathway to treatment may have included stigmatizing or discriminatory barriers, or it may have begun with a traumatizing interaction with law enforcement or involuntary hospitalization, leading to mistrust in the mental health system and ultimately delayed engagement in treatment. FIRST is not appropriate for individuals whose psychotic symptoms are known to be caused by the temporary effects of substance abuse or another medical condition, or they have an intellectual disability that impairs their ability to understand all treatment components. All right, I'm going to hand it over to Micah to tell you all about the IPS model of supported employment and education.
Hello, everyone. I'm Micah Stedemeyer. I'm the program manager for supported employment. So I'm going to tell you guys a little bit about supported employment in this department within FIRST. Supported employment will be made up right now of 2 specialists, as well as myself as the program manager. So supported employment and education is an evidence-based practice. We go by the IPS model, which is the individual placement and support. And we have 8 core values, as you can see, and they all are very important, but the one that I find most important is the 0 exclusion, which basically means everyone is included, or inclusion. We take clients regardless if they are symptomatic or currently using drugs or alcohol. If they're ready to work and willing to work, we assist them with finding jobs and education of their preference. One good thing is we have time unlimited support, so we support them to however they need throughout this process. And another great thing about supported employment is we will be doing the work incentive benefit planning in-house to help clients make sure that they're able to keep their benefits. And right now we have 1 specialist, and that is Teresa Thompson, who will be assisting clients for the FIRST and STARS program. Thank you, Steve.
All right, let's talk about how to make referrals to FIRST. If you are a primary care or a psychiatric provider and you think a client may benefit from this program, all you need to do is place a referral to care coordination and indicate that this may be an appropriate case for the FIRST team to review. If you are a counselor, an assessment team member, rapid access, urgent care, or a case manager, you will follow the internal referral process in Epic that we'll talk about on the next slide. All right, so let's say you have a client who meets the criteria for FIRST listed below, or maybe you don't entirely remember all of the criteria for FIRST. No one is expected to remember every detail of this presentation. All the same, just send an internal referral in Epic by pressing the button that says FIRST/CFS. It will then require you to give us a brief summary of why you are making the referral, and it'll allow you to select the service lines the client is interested in. On the other hand, if you have questions or want to consult about a potential referral, please just reach out to me, Teams, Epic, email. I'm happy to talk things through. So once you submit the referral, I will review the client's chart and contact them to verify what services they're interested in and to answer any questions they may have about the process of the program. Next, I will review the case with the rest of the team in one of our team meetings. I'll go ahead and schedule the client with our psychiatric provider for a psych eval and with our therapist if the client needs an initial or an updated mental health assessment. Even if psychiatry is not one of the services a client is interested in, an initial appointment with the psychiatrist may still occur to gather additional information to confirm their eligibility for the program. Clients will not be expected to meet with the psychiatrist ever again if they're not interested in that service. And lastly, once the case is accepted by me, by the team and the psychiatrist, and the client has accepted and the client has consented to at least 2 service lines, they will be enrolled into the program in Epic and services will begin. Clients do not have to transition all of their services to the program if it's not clinically indicated. I get this question a lot. So for example, let's say a client has a great relationship with their current psych provider and they would also benefit from FIRST services. They do not need to switch over to our psych provider as long as they are participating in 2 other services within our program in addition to engaging with that current provider, then there will be no need to transition them entirely. And on a side note, I will send out an email to everyone with digital copies of the FIRST program flyer and the external referral form, which you can use to quickly reference information about the program, its criteria, or you can even email them to clients or other providers who may be interested in learning more about the program. All right, I want to share some stories with you about 2 clients who are currently receiving services in the program. Please note that all identifying information has been altered to maintain confidentiality. So first, we have Terrence. Terrence is a 16-year-old high school junior who was referred to the FIRST program in September after his first psychiatric hospitalization this summer, where he was diagnosed with schizophreniform disorder and discharged on a low dose of aripiprazole. He lives with his mother and 3 younger siblings and has not been able to return to school this year because of comorbid anxiety symptoms. despite a history of strong attendance and average grades prior to his first episode. Terrence has had strong engagement with his therapist on the first team, who is helping him understand his symptoms, helping him develop a toolbox of strategies to feel and function better, and encourages him to try new ways of relating and communicating with his mother. He practices social conversations during their meetings in the community by challenging himself to order food at restaurants or to make small talk with people at stores. His first family psychoeducation specialist has been working with the younger siblings to process their anxieties about the changes they have witnessed in their older brother. Terrence is also working with our supported employment specialist to continue his education. Currently, he is receiving part of his schooling through home instruction, and with this support, he has recently been able to successfully return to school in the afternoons for his chemistry class. He is now on track to graduate with his class and hopes to study at Tri-C after he graduates high school. This case illustrates the positive impact of multidisciplinary first teams can have on a client's outcomes and recovery, with each specialist working alongside another to ensure that multiple areas of an individual's life are addressed. All right, now let's talk about Zariah. Again, identifying information has been altered. Zariah is a 20-year-old young woman who is currently staying in a group home. She has had 5 hospitalizations over the past 18 months for psychosis, most recently discharged on a long-acting injectable medication. She met with her psychiatrist on the first team 3 times in the first month after discharge, but suddenly became hesitant about receiving her next upcoming injection. So we know from the literature that having knowledgeable and supportive family or loved ones involved in treatment improves outcomes such as increased treatment adherence, fewer rehospitalizations, and improved family relationships. So with this in mind, we encourage Zariah to invite someone from her support system to attend her next psychiatry appointment to help her feel more comfortable and to ask questions about her treatment. She brought her grandfather, and with him supporting her at her next appointment, Zariah was able to feel less apprehensive and more informed about her treatment options. She ended up choosing to get her next injection and agreed to continue following up with her psychiatrist. She is also working with her therapist on the first team on understanding and practicing ways to stay physically and emotionally healthy and to increase her appreciation of her own strengths and self-value. Her case manager on the first team is helping her become more autonomous in her self-care at the group home because Zariah actually wants to get her own apartment soon. She is also working with her supported employment specialist to find a part-time job based on her interests. She has her high school diploma, but she never wanted to pursue further education because she felt generally uninterested in most topics. But now that she has started to see improvements throughout treatment, she has asked her supported employment specialist to help her enroll at Tri-C to take 1 class because she's feeling more motivated about her future. The first program is just one of the services we are offering in STARS, kind of like Ellie said at the beginning. I'm going to pass it along to Nathan and Ellie to discuss our future plans as we continue to grow.
Nate, you want me to take this one?
Sure, go for it.
Okay, so as you know, everyone mentioned, we have our first program that we have kind of humming along now and growing, but we have grander plans for doing more things as we develop. And one of those things is, as we're moving towards integration, is to have comprehensive medical care for all of our patients with schizophrenia and psychotic disorders. Some of y'all have heard me say this before, or even Eric say this before, but people with severe and persistent mental illness died 20 to 30 years younger than the general population. And that is not due to suicide. Typically, that is usually due to chronic medical comorbidities. So our goal is to be able to holistically wrap around these patients and really address their medical needs as well. So, we want to start with the first age people, but we really want to be able to take care of people throughout their lifespan. We are going to continue to be able to do work in the community. And we are developing a clozapine clinic. So that's going to serve all of our psychiatric providers in our clinic. And just a note about clozapine. So clozapine it's a medication that's used to treat schizophrenia. It's one of the best evidence-based medications, but there's a lot of monitoring parameters that go with it, including weekly blood draws, and a lot of follow-up. And so it's difficult for providers to manage all that if they don't have a lot of support. So we're developing a clozapine clinic for that. We're developing case consultations where providers within our clinic community can consult with Dr. McNamara and myself about tough cases, because our goal, of course, is not to steal all the patients with schizophrenia from our greater clinic community. We want to be able to support everyone who's taking care of this patient population. And then we're also working towards having integrated substance use disorder services within our STARS clinic, because we know there's a lot of comorbidity there.
Yeah. Just a couple of things to add to that. We are looking to start a family support group as well. It's something that we're looking to do to provide services to families who need a place to come and to find support with each other and to build a community around that, regardless of whether or not their loved ones are getting services from us, so that we can engage the community as a whole. And we're also tied into a lot of the networks around first episode psychosis and psychosis and schizophrenia in general, and we'll be consistently looking to what are some other treatment modalities that we could look into. I know it, off the top of my head, remediation therapy, if you're familiar with that, is something that is of interest. There's some really great work coming out of Britain on the Talking with Voices movement, and doing some didactic type therapies with persons talking with their voices and understanding them better. So this is only the beginning, and I hope that we can continue this great work with the team, which now, with all these things we're doing, let's talk about the team and who's on the team here. So team members for the STARS program, of course, the four of us who have presented today, and then we also have Dr. McNamara, who will be our psychiatrist on the team. So Dr. Mac, if you'd like to give a little wave. All right. Lavette Ederson is our counselor on the team. We have Taisha Reed, case manager. We have Brianna Lewis. Is Brianna back yet, Steve, by the way? No, she's out on her honeymoon. So congratulations to Bree. And then Teresa Thompson, who is our supported employment specialist. So Teresa, give a little hey to everybody. All right. So again, if you have any questions about the STARS programming, we do have an email address that goes to the leadership. So this would be stars@thecentersohio.org. So I'm going to stop sharing the presentation so that we can start the question and answer portion of this program.
And it looks like
Caitlin?
yeah,
Caitlin,
so
yeah.
go for it.
Hello. Hi, everyone. So I just had a quick question because we've actually had a couple of children come through that have presented with psychosis. So, and I know that you guys work with individuals 15 and up, but do you have any resources or appropriate recommendations for, for those children that we might see with psychosis?
So are you saying like under the age of 15?
Mm-hmm.
Where are you seeing these children at?
Behavioral health urgent care.
So I would say if you're seeing a child under 15 and you're concerned that they're presenting with symptoms of psychosis, that even though they would be too young for FIRST or for STARS, that child bears a consultation with one of the child psychiatrists at the centers. And I know that will be me and Vince, and Vince has a fellow with him, and I don't know who else is child trained. Does that make sense?
Yes, thank you very much.
I think
I have a
Molo?
question.
Yes.
My question is, if as a provider, once we've seen this patient and we tell them about the program, we send the referral, what do we tell them would be a turnaround time for them to expect to hear from someone?
Oh, that's actually rather quick. Something that is a benefit of having such a small team, in addition to being rather new, is, there's a cap. We can't take on too much. So if I get a referral, let's say today, I am either reviewing it today or tomorrow and calling the client today or tomorrow and getting them in with Dr. Mack either the end of this week or early next week. So it's a pretty quick turnaround.
Thank you.
Hi. So I think you guys are already doing so much and it's so great, but I just am thinking about so I used to work in crisis in Lorain County, and we used to get a lot of calls from like local police departments saying that like this person keeps calling us over and over again, reporting multiple things. And so we would go out to the home and see them, and most of the time they would talk to us, but they weren't meeting, criteria to go to the hospital. I was just curious if you guys had any like thoughts or contact with like the co-responder team in Cleveland or Cleveland Police Department. Because I feel like a lot of times people are reaching out to them first, and it could be a good way to like intervene.
Yeah, that's a great question. And actually, there was a Tamara asked as well if we were accepting external referrals into the system. So I think these kind of go hand in hand. So one of the administrative functions that Steve and I will be providing is doing that community outreach piece. We have a plan together of getting information out to school systems, colleges, community stakeholders. And we've started some of, to start on that, we've had a few meetings with community partners. We're looking to do a more formal external launch in the new year. And that's when we will really kick that up. And part of the plan is to have contact with the CIT officers and the paired officers as well.
Nice.
I definitely appreciate that.
Yeah. Is this the only FIRST program in Cuyahoga right now?
It is not. There is a team at Catholic Charities as well. They are providing services mostly to the west side. Although I do know we have had contact with a few hospital systems and with frontline services as well. And even with a little bit of informing the community that we've done, we've had a significant amount of external referrals already that we've processed through. And I think, Steve, even from like our telephone number and website that we haven't really published all that much yet, we've gotten 5 or 6 referrals that were self-referrals. So.
Okay.
Yeah, so the way that external referrals work, to answer Tamara's question, is one, we have a dedicated phone number to that goes directly to the first episode program. We have on the center's website, if you want to check it out, there is a specific page for FIRST that has all of our information and a like a self-referral form, like a, hey, this is my name and my number, and I'm interested in learning about the services. We've been accepting external referrals, I think, since July. And, working with hospitals, frontline, like Nathan said. We also, I'm not sure if everyone has received them yet, but we passed around some like informational stuff that marketing helped us put together. Thank you to all of them. But there are the physical form of the flyer, and there is a physical external referral form. Again, I will send out the digital copies. So if it's someone that you're working with or a provider that you're consulting with, you can either give them that or shoot them an email with that information. They will fill out the referral form and they'll send it back to me.
And Steve or Nate, I think at this point, while just doing internal referrals and like the word of mouth, we haven't really done, this is our first launch essentially, and it's internal. How many clients do we have right now?
First clients, we have 18, and STARS clients that are actively engaged, there are about 15, I believe.
Yeah, which is incredible so far.
Yeah, we've been moving along a lot faster than we had anticipated. Anyone else have any questions?
Oop,
And Nick,
Sorry, I was muted. There was a question on the chat about if a client has case management services, can they be referred to STARS? The answer to that would be yes, although at the present time, we're not accepting STARS referrals at this given time. We will definitely get the information out when we are, but yes, as long as they're able to, or as long as they're willing to take part in at least 2 of our service lines. And correct me if I'm wrong, Steve, but
yes, yeah. So STARS is unfortunately on hold now that we are launching internally, and very near in the future we are going to launch externally. We just want to be mindful that it's possible that we'll see a spike in referrals. So we want to make sure that our team is dedicated to the FIRST program for now. We of course are going to continue to grow and expand. So those referrals will open up as soon as we have the staffing to, appropriately treat everyone. And Tatiana from marketing, thank you for reminding me. In addition to the flyer, which of course is a regular sheet of paper, like size-wise, we have these little wallet size ones, which are really cool, that marketing has gotten for us. You should have, some of you might have them at your sites. We'll work on getting more out. Yes, thanks, Barb. They literally will fit in your wallet, so we can hand those out to clients, or you can keep it on yourself or in your desk drawer if you need. It has all of the important information that you will need to be able to explain this program to someone else or a client or anything like that.
Nate and Steve, I saw a couple of confused looks when we said we're not accepting referrals. You're talking about for the bigger picture for the group outside of the FIRST program.
Yeah, so those who do not meet criteria for FIRST, whether
Yes,
they're too old or they've had symptoms for a lot longer than, so they're not, having their first episode.
Yep. So that's our future plan, to accept people outside of FIRST. We're just not there yet, but we are accepting FIRST referrals.
correct.
I had one question. Maybe I missed it in the first part of the program, but at what locations will services be available?
We are housed at the East location, Midtown. We are community-based, so we have the ability to go to clients' houses or meet them in a community setting. So if transportation or location is an issue, we can remedy that. And if any of you are like me, I usually think of questions that I want to ask after the fact. I don't know why my brain works that way, but please reach out to any of us and we are happy to talk one-on-one.
Or send an email to stars@thecentersohio.org.
I just realized that I did want to we are utilizing our nurse, Tracy Myers, who is the ACT team nurse and has also been pulling double duty and taking care of all of our STARS patients. And I'd be amiss. I saw her face and I said, oh man, if I didn't express our gratitude, because she's doing 2 essentially full-time jobs right now as the nurse for both programs. And we couldn't do it without her. So thanks, Tracy. And we are looking for a full-time nurse for the STARS program. If anybody, I know it's like finding a unicorn right now, but if anyone knows anyone, we are looking for someone who wants to work just in this program with us. But in the meantime, Tracy is our unicorn.
Any other questions from the group or comments? No? Okay. Well, I definitely appreciate you all joining us today. And I know that the team is looking forward to starting 2023 and providing these services to the community, letting the community know about these services. So as we are looking at that external launch, we'll be communicating out when that will be happening. And it would be great if you all could share that with your networks and social networks, because there will be some social network campaigns around that as well. So again, thank you all for joining. If you have any questions or thoughts after the fact, please send those to stars@thecentersohio.org or to reach out to us. And again, thank you to the team for being here today and for putting this presentation together in the marketing department.
Thank you.
All right. Thanks, everyone.
Have a good day.
Thank you.
Bye-bye.
Okay. Bye-bye.
Thank you.
Thank you.